I'm a pediatric hospitalist here at Kapiolani, and am part of this Recover study that I'm going to tell you a little bit more about, but also exploring what our role here in Hawaii is for patients with pediatric long COVID. And then obviously we'll turn it over to Dr. Rowe. As I mentioned, I don't have any disclosures, and our objectives are kind of what Melissa already shared. So the first thing I want to do is kind of give you some framework behind what our experience with COVID in general was, and then move from there into long COVID. And you can see here the pediatric hospitalizations that we had here in Hawaii compared to those in the continental US. So the solid line is represented by our patients, our pediatric patients here in Hawaii, and then the dotted line was the US mainland. And generally, kind of at the beginning, we're following those different surges, but you can see towards the end, we really pushed our major pediatric hospitalization surges. They were delayed beyond what we saw on the mainland. And as you know, this delay wasn't accidental. Hawaii implemented some of the strictest public health measures in the country. We had mandatory quarantines, travel restrictions, stay-at-home orders. We had closures of school and limitation of sports after school and extracurriculars. And so those measures likely contributed to us seeing this really delayed peak and surges of our pediatric COVID-19 hospitalizations. This table here was from our examination of our pediatric patients who were admitted with acute COVID. And we compared it to our general pediatric population here in Hawaii, looking at male versus female, government versus commercial insurance types, and then by race. In our hospitalized cohort, we saw significantly more male patients, 62.1%. 71.9% of the patients had government insurance, and we had a disproportionately higher number of Native Hawaiian and Pacific Islander children, which you can see on this chart. What's interesting is that in other studies across the country in pediatric populations, they did not see that higher prevalence in male patients. So that was something new that we saw and something that we are investigating further. But data like this, I think, really reinforces why our participation in national studies is so important. Without it, the experience of our Native Hawaiian, Pacific Islander, and mixed race children risk being underrepresented or overlooked entirely. And so that leads me to how we became involved in a national study. So the Recover Pediatric Study, which stands for Researching COVID and Enhancing Recovery, is really this long COVID study that we've been lucky enough to be a part of. And how it originally happened is we joined this ECHO IDEA states, which are research that's conducted in 18 sites and states across the country that have had historically low NIH funding. And then through that network, we became a part of the hub for NYU and were able to participate in the Recover study. There's 103 pediatric sites across the country, and it's structured to enroll 15,000 participants from birth to age 25, along with their parents and caregivers. And it's a really nice longitudinal study spanning 4 years. Here at Kapiolani, we have contributed meaningfully with 63 participants enrolled to date, and again, really hoping to contribute our diverse pediatric population into this national data. The way the study is set up is there are 3 tiers, and those are composed of patients who were infected with COVID and we're in that active period, so within the first few weeks of infection. Those patients who actually at the time had no documentation or recollection of having a COVID infection, and as you can imagine, that's a much smaller population. And then those that were infected but were greater than 30 days out. And then you kind of follow these through and you see the different arms of their high probability of long COVID versus those with lower probability. And again, just, what you all know is why pediatric long COVID research is so important is that most of the long COVID we've seen has been, the research has been focused on adults. And we really needed pediatric specific data to even guide diagnosis, management, and hopefully eventually treatment. And that's where the RECOVER study is going to play a critical role. And the study asks those questions that we need answered. Why do some of these children develop long COVID symptoms and others don't? What symptoms are the most common? How long do they last? What are the underlying risk factors or causes for long COVID? And these aren't just theoretical questions. They're what we need to build the tools, treatments, and future clinics. I mentioned PASC, so by definition, we're using that interchangeably with long COVID, and this was one of the first articles that came out in pediatrics. And here, the NIH kind of just broadly defined what post-acute sequelae of SARS-CoV-2 look like. And that could be either it was an exacerbation of a pre-existing condition. So in this case, you may think about a child who has asthma and now goes on to kind of have persistent or worsening asthma symptoms. It could be persistent symptoms that they had during their acute COVID infection that continues on. So that may be fatigue, or that could be headaches. And then the last are these de novo conditions, or entirely new symptoms or diagnoses that appear after infection. So these may be some of the autoimmune conditions or other things. And then they leave MIS-C as a separate entity altogether at the bottom. And I don't think I really need to, I think you know the impacts, but to ground this data in real life, I wanted to share a quote from one of the parents of our study participants. Her daughter had COVID in December 2022, and months later was still dealing with debilitating fatigue, brain fog, and pain. And it was so severe that she was no longer able to attend school. And this is the reality for the families who are dealing with children who have pediatric long COVID. And what makes it so challenging is it's not showing up in labs or imaging, but obviously the day-to-day impact is profound. And what makes this work so urgent is that we don't have a good way currently here in Hawaii or at Kapiolani to capture these patients other than through our study. They're coming in through different subspecialty clinics. And how can we best identify all these patients and get them into one area? This slide shows the demographic characteristics currently of the National RECOVER Pediatric Cohort, just to give you a sense of the good job that they've done on the broad geographic and racial diversity that they have. There are, you can see here the percentages, and then I really appreciated, obviously, those patients from medically underserved areas who are going to have more challenges in access to care, and again, may not have access to long COVID clinics that are present at bigger centers. So from our early RECOVER data, this is what we've already seen. Long COVID symptoms occur in almost every organ system of the body. We do think there are symptom patterns that differ by age group, which I'll go more into. And they did help create a research tool, which hopefully we can move over to a clinical tool to help us identify those children who are most likely to have COVID. So this slide highlights symptom differences between children who had COVID and those who didn't. And then what you see in the middle is those symptoms that were most common in both school-age children and adolescents who had COVID. And you can see, just like I talked about in the last slide, it's really affecting every organ system and causes a wide variety of symptoms. But when they went and used advanced statistical techniques using LASSO, they were able to identify those symptoms that were most strongly linked with a prior COVID infection. And so by using LASSO regression, they looked at it, and this is what they came up with for school-age children. So again, we're not even talking about the really young children. We're talking about the school-age, the preteens. And you can see here, these were the symptoms that they came up with. And then they use a scoring system that we can then calculate and see from there, are they long PASC unspecified, so long COVID unspecified, or PASC probable. And I think what's important here is we're not saying they don't have long COVID. We're just pointing out those that are probable. And then these are the 8 symptoms that we saw more in adolescents. And you can see a little more of the fatigue and the daytime sleepiness and the headache, whereas in the younger children, a lot more of those other symptoms of stomach, a lot of stomach aches for them, school refusal, nausea, vomiting. And so what this brings us to is what's really next for Hawaii. We don't have a dedicated pediatric long COVID clinic, but we have data and we have the need and we have the momentum. So we have patients that we're identifying through our research study. We have other families who, because of the outreach we've done around that and sharing our data, have come forward and said, I think my child has long COVID. And we're so thankful for Dominic Chow and his group because they do see children who are over 15. But what do we do for these younger children? And the RECOVER study is still evolving. We've got biospecimens collected. So future phases are going to look at things like EBV reactivation, genetic risk factors, immune system profiling. They just talked about that they might be doing a drug trial with naltrexone. And so a lot of work is still being done and a lot more data will be coming out, and I think more papers that will help us. But I think what's really important here is what Dr. Rowe has to say next, and how can we take some of that information and how can we build upon that so that we can move forward to build an infrastructure for these patients and create a path forward for them. So I'll turn it over to Dr. Rowe.
Great. Let me bring my slides up as well. Jessica, that was a really nice introduction. Let's see. All right, let's get that one going. Okay, so I'm going to talk about diagnosis and management. I've been the director. I'm a general pediatrician by training, but have always done more problem-based clinics in the hospital setting. And in the mid-1990s, we made some observations about chronic fatigue syndrome, and were suddenly flooded with requests to see hundreds of patients. So I have, since the mid-1990s, focused just on the treatment of chronic fatigue syndrome and related conditions, including long COVID. So the slides I'm presenting have been put together by me with my colleagues, Dr. Camille Broussard and Dr. Alba Azola, who's an adult physical medicine and rehab physician. So I mentioned the one-time consultation to CSL Behring, but and I'll be discussing some off-label use of medications, mostly because the drugs that have been approved for treating orthostatic intolerance haven't been formally studied for that purpose. So I want to look at the new long COVID definition from the National Academies of Science, Engineering, and Medicine. And then I want to spend a lot of time looking at the overlaps with pre-pandemic ME/CFS, which stands for myalgic encephalomyelitis chronic fatigue syndrome. That's the term used for what we used to call chronic fatigue syndrome, now by the NIH and the CDC. And then I want to present some very practical clinical suggestions about how you can approach the clinical care of these patients, given that we don't have as many specialty clinics and specialists as the numbers would require. So I think many people in general pediatrics will need to become familiar with these kinds of things. And I think you'll find, as you hear the talk, that that these are concepts that are familiar to any generalist. So the definition that came out from the National Academies in 2024 said that this was an infection-associated chronic condition that occurs after SARS and is present for at least 3 months, and it can be continuous, relapsing and remitting, or progressive. And as Jessica mentioned, it can affect any real disease state. And some of these are obviously, identifiable if you had a patient who's been admitted to hospital and is left with bad lung disease or blood clots or chronic kidney disease. But one of the things that is the most prevalent is the form of this that it leads to fairly dramatic impairment and mimics myalgic encephalomyelitis chronic fatigue syndrome. So we'll spend more time on that. We've recognized from the early part of the pandemic that a substantial number of these patients who have persistent symptoms more than 6 months after COVID meet criteria for ME/CFS. And they look very much to us like the ones who had their illness initiated before the pandemic, for example, after Epstein-Barr virus infection. So thankfully, we can draw on a lot of the clinical understandings from pre-pandemic ME/CFS to treat the patients post-pandemic. So one of the things that defines ME/CFS is the 2015 Institute of Medicine criteria. And so this required that patients who meet the ME/CFS criteria have a substantial reduction or impairment in their ability to engage in things that they used to be able to do before the illness. And this is accompanied almost always by profound fatigue. But the Institute of Medicine definition puts the emphasis on the fact that people can't do what they used to be able to do quite easily. The second core feature is something called post-exertional malaise, also termed post-exertional symptom exacerbation. And this is the worsening not just of fatigue, but a variety of other symptoms after patients exceed their usual physical or cognitive efforts. And PEM can persist for more than 24 hours. Patients refer to this as a crash. The third core symptom was unrefreshing sleep. And you could have either cognitive impairment or as patients refer to it, brain fog, or one of the forms of orthostatic intolerance. Now, this was a definition that was meant to apply both to pediatric and adult patients. And at the time, orthostatic intolerance we felt was universal in the pediatric patients, but was only seen in about 40% of the adults. New data has shown that about 90% of adults with ME/CFS have reductions in brain blood flow when you do the right kinds of tests. So this probably would be a core symptom today. The symptoms have to be there for at least 6 months, affect patients at least half the time, and have at least moderate severity. In terms of long COVID, the numbers are quite substantial. And as Jessica mentioned, it's a bit less common in the very young kids and the school-age children, and starts approaching and approximating the adult prevalence in adolescent patients. This was a study by Danilo Buonsenso, who's an Italian pediatrician, published pretty early on in 2021. And these were the symptoms that were reported at a mean of 163 days after a positive confirmation of SARS-CoV-2. So this was all ages that he described. So insomnia was common, respiratory problems, nasal congestion, and then you start seeing the symptoms that overlap with chronic fatigue syndrome, namely fatigue, concentration problems, and then a variety of pain symptoms. I'm not going to spend any time on this because Jessica covered it so nicely. This was from one of the papers from the RECOVER study, again emphasizing that there are slightly different symptoms in the 6 to 11-year-olds compared to the 12 to 17-year-olds. Danilo Buonsenso and his group in Rome also looked at the odds ratio for persistent long COVID symptoms. And this was a prospective study they did. And on the left, you see the odds of symptoms persisting at the 3-month point. And so older age is a risk factor. Having comorbid medical problems was a risk factor. Being asymptomatic at the time of the COVID infection was actually protective. Although it's important to emphasize that because so many of the patients that we see have mild or asymptomatic infection and being hospitalized is so uncommon, in the aggregate, more people come into long COVID clinics who have had mild infections. The Omicron variant also was less likely to cause long COVID than were some of the earlier variants. And then hospitalization was a big risk factor. And very similar results were seen at the 6-month point. They also looked preliminarily at the prevalence of long COVID in children and then adolescents based on their vaccination status. And I think if you focus on the 6-month data in the tan color, you can see a trend towards protection against long COVID if people had completed their vaccination series. So we know that long COVID can have major impacts on adolescents because of the fact that they're going through all kinds of transitions to independence. And these symptoms can really limit their participation in sports, extracurricular activities, and especially education. We don't have completely good, thorough data on prognosis, but patients who have not recovered by 6 to 9 months have a lower probability of recovering within the next 1 or 2 years. And in one study, less than 10% recovered completely. And the ones who did recover completely were more likely to have milder symptoms. So the long-term prognosis is still under active investigation. So I want to focus on the approach that we've developed to long COVID and to ME/CFS. And this involves evaluating and treating the common conditions that people have. And we focus a lot on orthostatic intolerance. So in the beginning, you want to get information on the onset of symptoms, their duration, find out about how the person is doing in a typical day, what impact this has had on their schooling or sports activities. And it's especially important to assess for post-exertional malaise, this exacerbation of symptoms after a relatively more active day. Orthostatic intolerance, we want to know about cognitive dysfunction, and that's harder to tell from an interview, so we usually use something like an ADD type questionnaire. We want to know about mood state and then ask about prior associated medical problems. The physical exam needs to be a complete one that includes a careful neurologic examination. We do a Beighton score that I'll show you in a second because hypermobility is a fairly substantial risk factor for ME/CFS, and it's emerging from data that it's also a risk factor for long COVID. And so knowing that the patient is hypermobile, I think will turn out to be an increasingly important factor to assess. We also look for range of motion of the limbs and spine, usually using techniques that physical therapists typically use. So you may want to lean on your physical therapy colleagues to look for this. And this seems paradoxical that patients could be both hypermobile and also tight on their range of motion examinations, but that's also seen in people with joint hypermobility. In terms of lab studies, anyone in pediatrics knows what to do here because these are basically the same labs that we would draw for people with failure to thrive. So we're looking for hidden organ system dysfunction, CBC, CMP, some measure of inflammation, iron, vitamin D, vitamin B12, because that can be a trigger of fatigue. And we get a urinalysis, and we often will check a histamine and a tryptase because mast cell problems are often triggered by COVID infection and seem to be part of what contributes to the perpetuation of symptoms. And then in all of the patients we see with this degree of fatigue and impairment, we do a 10-minute standing test that you can do in the office. You don't need any fancy equipment for that, and I'll show you how to do that in a second. This is the Beighton score, which takes maybe a minute or two, where you look for the ability to dorsiflex the fifth finger at the metacarpophalangeal joint, as you see in this box, past 90 degrees. You get a point on each side for the ability to do that. You get a point for the ability to bring the thumb into apposition with the forearm. You get a point, as you see on the bottom, on each side for measuring the degree of hyperextensibility beyond 190 degrees. And you have to use a goniometer. One of these little plastic $7 goniometers is very good, and you get quite good at measuring that angle. And the same thing goes for hyperextension at the knees. And then the ninth point is for the ability to bend forward and put your palms flat on the floor. And hypermobility is consistent with a Beighton score of 4 or higher. The maximum is a score of 9. Some people would say 5 should be the cut point. We've used 4 in our research. Orthostatic intolerance refers to a group of clinical conditions in which symptoms will worsen with quiet upright posture. That can include sitting for long periods of time, like you would in a long classroom, or standing. And those symptoms are usually ameliorated, but they're not necessarily abolished by lying back down again. And 2 points are worth making here. One is that once you've provoked fatigue with orthostatic stress, it can last for up to a couple of days. So it's not going to get better immediately on lying down. And the same goes for once you've provoked brain fog. Of the forms of orthostatic intolerance, and I'll show you the entire range of them in a second, postural tachycardia syndrome is the best known of these. And that requires an increase in heart rate of 40 beats per minute from supine to the first 10 minutes of standing. In children who are 20 and older, adults who are 20 and older, it only requires a 30 beat increase. So this slide shows one of the main challenges that we all face when we move from supine to standing, and that is that there's a shift of about 500 to 750 milliliters of blood into the lower half of the body, as you see on the left, and that increases venous pressure. There is less blood immediately returning to the heart. And in people who have different forms of orthostatic intolerance, you can often see what's seen in the picture here, a fairly prominent degree of acrocyanosis. Here's somebody who dropped out of college with her ME/CFS, and I went over and pressed my fingers on her skin looking for capillary refill. I stepped back, grabbed my camera. My son will tell you I'm not very good at handling my phone. So I found the camera icon, I focused it, and it took the picture. This was about 7 or 8 seconds after this girl had my fingers pressing on her skin. So this was very poor capillary refill. The main factors that go into the different forms of orthostatic intolerance are that these patients have an increase in the amount of blood that they pool in the limbs and perhaps a defect in their ability to vasoconstrict. We think in the hypermobile patients, they've just got stretchier vessels. So when that column of blood goes down, pushing outward on the vessel, they're going to dilate and accommodate way more blood volume. Patients who get blood volume measurements in research studies also have about a 10% reduction in their intravascular volume. So when you combine those two things and people are put on a tilt table or are given the passive standing test, there's a substantial reduction in their brain blood flow. That then elicits a marked sympathoadrenal response, big increases in epinephrine and norepinephrine. And the phenotype can be either classical orthostatic hypotension, which is seen much more commonly in older adults. That's a drop of 20 systolic or 10 diastolic in the first 3 minutes upright. Delayed orthostatic hypotension is the same drop in pressures, but occurring after the 3-minute point. We've given the term neurally mediated hypotension to the same physiology that you see with vasovagal syncope, but not all these patients who have that on the tilt table or the standing test have fainted in day-to-day life. So we've termed it neurally mediated or reflex hypotension. We mentioned POTS. And then it's also emerging that, especially in adults, a lot of them have low orthostatic tolerance, but they have a normal heart rate and blood pressure response despite a major reduction in their brain blood flow. So adolescents often think that everybody has what they have. So you want to ask them not just, do you feel lightheaded? Because I had a girl one time saying, oh, I don't get lightheaded. Well, what happens when you stand up? Oh, I get a head rush. Well, a head rush to me is the same as being lightheaded. And you have to ask them very specifically, how do you feel in positions of quiet upright posture? Like, how do you do waiting in line? How do you do at the shopping mall? And my comment to our trainees is that if you've got an adolescent who can't tolerate being at the shopping mall for more than 5 minutes before wanting to go home, you've got a medical problem until proven otherwise. They do poorly if they're standing at a cocktail party, at a reception, in a concert, at a religious service. And they do very poorly when you combine the upright stress with the heat stress. So you have to ask, how do you do in the shower? Do you have to sit down in the shower? People don't volunteer that information. Or do you have to lie down after a hot shower? How do you do on a really hot day or in a hot room? And the symptoms that you can get with orthostatic intolerance span the entire range of things that we see in ME/CFS and long COVID. So it can include lightheadedness, presyncope, fatigue for sure. They're intolerant of exercise. They can get headaches when they're upright for long periods of time. They get brain fog if they're upright for too much time. And then perhaps because of the high catecholamine state, they can get chest pain, palpitations, increased anxiety, and excessive sweating. So the way that we do the in-office test is we have them lying supine for 5 minutes, and we check a blood pressure and a heart rate each minute using an automated blood pressure cuff. Then they stand and they lean their shoulders back against the wall, and then we record the blood pressure and heart rate each minute for 10 minutes, and then we have them lie back down for 2 minutes afterwards. And throughout, as you see on the top line of the graphic, we're asking them to rate a variety of symptoms on a 0 to 10 scale, with 0 meaning not present. So fatigue, lightheadedness, cognitive fogginess, headaches, and so on. So here's an example of a 20-year-old that we studied, and you can see in the supine position, the resting heart rate is between 68 and 72. Blood pressure is pretty normal. Fatigue is listed as a 2 out of 10. Lightheadedness 0 out of 10. And with standing, you see this progressive increase in heart rate so that by the 7-minute point, you've got a sustained increase in the 107 to 109 range associated with provocation of worse fatigue and worse lightheadedness, as well as cognitive fogginess. And this is a very good thing for parents to see, because if they don't really think the kid is sick, and then they see how unwell they feel just with standing still, you've got a problem. So here's the peak heart rate. There's the lowest supine heart rate, and you subtract those, and you get a 44 beat increase, which is consistent with POTS. Let's see. So in terms of treatment options for orthostatic intolerance, I just want to review this briefly, and then I'll have some references for you that give you the doses that you might need. The non-pharmacologic therapy everybody gets, right? You want to have most adolescents drinking 2 to 3 liters a day of water supplemented by salt tablets or liquid IV, increase their dietary salt intake. You can try to get adolescents to wear compression garments. I've gone hoarse many times trying to recommend compression garments. Cooling garments are good in the hot weather. And many of them adopt these postural countermaneuvers where they cross their legs when they're standing, or they sit with their knees up to their chest. We want them to avoid complete bed rest where possible. Then we move fairly quickly on to pharmacologic therapy using either vasoconstrictors to improve the return of blood to the heart, volume expanders, or drugs that can affect the high catecholamine state. Among the vasoconstrictors, the nice thing is that many pediatricians know exactly how to use the class of stimulants, right? Same doses that we would use for ADHD. Midodrine is a non-stimulant vasoconstrictor, the disadvantage of which is that it only is active for about 4 hours after a dose, so you need multiple doses per day. Some of the SSRI and SNRI drugs also can vasoconstrict to some extent. Droxidopa is typically reserved for people with Parkinson's at the other end of the age spectrum. For volume expansion, we use a lot of increased sodium to draw water into the vasculature. If we need to use prescription medications, we try fludrocortisone or Florinef. Clonidine, interestingly, even though it's an antihypertensive, can expand blood volume in some patients with orthostatic intolerance. Birth control pills have some utility in this regard as well. So, for example, in a young adolescent girl who gets really fatigued at the time of her period, our first line choice might be a birth control pill, using it on a continuous basis so they have only one period every 3 months. Desmopressin can be used at bedtime to help reduce urine formation, but you have to be very careful that you're not causing hyponatremia. In terms of drugs that affect heart rate, the mainstay is usually the beta blocker drugs. Again, everybody's familiar with how to prescribe propranolol or atenolol. The SSRIs probably can affect catecholamine release centrally. Ivabradine is a very good new drug that just affects heart rate without affecting blood pressure, and this is the other name for this is Corlinor. And then pyridostigmine bromide, Mestinon, is a drug that we had used in the past for myasthenia gravis, but does a nice job balancing out the autonomic tone and can be transformative for some patients. It's a bit of a hunt and peck process, much like it used to be for finding the right thing for somebody with migraines, and you have to be willing to try several medications before you find a good fit. Sometimes medicines from each of those three main categories need to be combined. So we also know that standard forms of symptomatic therapy can be effective for not only the orthostatic intolerance, but their headaches or migraines, the menstrual dysfunction, if they have low mood or anxiety. And we tell people this is a journey, but we'll travel that road with them, and we keep going until we find something that's effective. In terms of management, you want to look at the functional impact of the symptoms on their schooling and other activities, and you can triage things based on what they describe as their most debilitating symptoms and also the ones that are most treatable. Some need subspecialty referral, but because they've got so many different systems involved, you don't want them going to 10 or 15 different subspecialists. And so often a generalist quarterback is really important to save them the time and effort. We tell people to avoid an excessive push crash cycle. My colleague, Dr. Azzola, calls it the Corona coaster, where on a good day, people will do a little bit more and then they'll crash for 2 days because of the post-exertional malaise. So we don't want them doubling or tripling their activity level on a good day. We want them to very gradually increase what they're able to do. Pacing is important. So you want to break activity tasks into small chunks, switch between activities that require different muscle groups. So go between reading versus walking. They probably need to rest between activities. And the increase in activity can't be according to somebody else's schedule. It always has to involve taking into account what that person's response to an increase in activity should be. And sometimes you need to treat their orthostatic intolerance before they can tolerate further activity. So we're always trying to avoid both complete bed rest where possible and then overdoing it. In adolescents and young adults, a later start to the day can be important to arrange with the school, as the morning is the time when their blood volume is at its lowest, so it's usually more of a symptomatic time. We ask for assignment flexibility and flexibility with scheduling tests. They often need 50% extra time for test taking because they're often so foggy. And then flexibility with make-up work assignments and absences. The key that we've found is these are not kids who are trying to avoid school. This is more of a I can't get to school rather than I don't want to go to school. And once they feel better, their school attendance improves substantially. They often will need permission to have access to fluids at their desk all through the day. I'm not going to spend a lot of time on this slide, but just to mention that our overall approach also looks for a variety of other comorbid conditions. And we published this in August in the pediatric clinics, along with references to treating all of these different things. And I'll just mention a couple of them, but here's the Ehlers-Danlos syndrome and the joint hypermobility. That affects about 60% of our patients. A very tiny subset will have neuroanatomic problems. This is why it's really important to do a careful neurologic examination. But let me focus on a couple of these. One of the problems that we see with increased frequency is mast cell activation syndrome, where patients come in with these blotchy red rashes that you see on this slide. This girl has a lot of redness on the face down to the upper chest. This girl's got blotchiness. This one has hives. They can have, really red ears and facial flushing. And the other things you can look for, along with the hives and the rashes, are that patients with mast cell activation have an exaggerated response to insect bites and bee stings, and they often have multiple foods or medications that they don't tolerate. In our chronic fatigue syndrome work, we found that 30%, which is a very high proportion, have a delayed reaction to milk protein intake. They get a triad of epigastric pain, early satiety, and reflux. Some of them have frequent aphthous ulcers, and the onset of symptoms is about 4 hours after their milk intake. So they don't always realize that milk is a problem, but look for that triad of symptoms. We're finding that many patients have difficulty putting their arms overhead. So, for example, girls or anyone with more hair than I've got on their heads, when they're shampooing their hair, they can get arm fatigue, numbness and tingling, or generalized fatigue. And they're often so used to these symptoms having been present for years that they don't really offer them. With hypermobility, ask them if they can do any tricks, if they're double jointed. And if they're active in dancing, cheerleading, gymnastics, or swimming, there's a very high likelihood that they're already hypermobile. So in summary, people should suspect a diagnosis of long COVID in people who present for care with these multi-system symptoms. And we think that they're presenting virtually identically to the people who had ME/CFS before the pandemic. So make sure to assess for orthostatic intolerance using this in-office 10-minute passive standing test. And you're looking for both the heart rate and blood pressure changes, but also whether they get symptoms provoked. Patients are usually able to gradually increase their activity, but they really need to focus on pacing to avoid PEM. I'm going to list a few resources that might be valuable to people. One of them on the left is an international primer put together by a number of those of us who work with ME/CFS patients around the world. That's an open access publication. It has all the doses you'd need for treating pain or migraines or orthostatic intolerance. We published a book that came out last August that's fairly inexpensive from the Johns Hopkins University Press that has more detail for patients and physicians. There are a number of guideline statements on the treatment of long COVID. Here's one by my colleague at Hopkins, Dr. Laura Malone, and many others from the physical medicine and rehab subspecialty. We did another review for current pediatric reports that gives you the dosing for orthostatic intolerance. And then our own experience with long COVID and how to treat it is in both the Pediatric Clinics article, and then at the bottom we did a case study just showing how we put these principles into play for a young university student with long COVID. And then at the end, I've listed a number of references, including in the middle of this slide, 3 webinars that we did looking in a bit more detail at the physiology and treatment of orthostatic intolerance and at the measure about joint hypermobility. I've listed some papers by my Dutch colleagues, Linda van Kampen and Frans Visser, who have been pioneers in measuring cerebral blood flow during upright posture in these patients. And then at the bottom is our paper on the prevalence of different orthostatic intolerance disorders in kids who came to the long COVID clinic. I'm going to stop there. Our work has mainly been helped and funded by private philanthropic efforts. And this is the team that I've been fortunate to work with for the last few years at Hopkins. So I'm going to stop there and see if we have time for questions, Jessica and Melissa. So let me know.
Yeah, absolutely. We're supposed to go till 5. And it looks like we do have a couple of questions in the chat. Would you like for me to read those?
You can see the one from Dr. Chow. So, uh, so Dr. Chow, and what we have, I have not seen the breakdown like they have for the adults. So at this point, they're just kind of categorizing them as groups by the two different age groups, the school-age children and then the adolescents. I suspect though more of that will come out in the next kind of group of papers.
Yeah, I just mentioned that primarily because the adult NIH Recover broke it down, thinking that the mechanisms were a bit different compared to the rest of the with individuals with GIV. And I was going to ask Dr. Rowe if do you think that there are different mechanisms for long COVID and ME/CSF in kind of like the different subgroups of kids who are there?
So, we have not seen that. I know there's been a lot of focus in the long COVID investigations looking for viral persistence as a major factor. But when we treat our long COVID patients, we're not doing anything that uses antiviral agents. We just treat them looking for their joint hypermobility, treat their orthostatic intolerance, treat their migraines. And that's been our way of getting them better. So our treatment is essentially what we've been doing for the last 30 years for the ME/CFS patients. Now, it may be that we find some underlying factor that's wrong with, say, the immune system or the immune response. But thus far, none of the studies have really come up with single treatments that are completely effective for everybody. And because we see such a mix of the different comorbid situations in these patients beforehand, it's probably never going to be the case that we have a single treatment that's really effective for everybody.
Okay, and we have a question that was asked earlier, and it says, what about other electrolytes? For example, a high potassium diet for patients without any potassium contraindications.
So we don't typically focus on their potassium intake. I'm not aware of any work that has suggested that that's an effective strategy. The biggest help for the patients who have orthostatic intolerance, and that's universal in the ME/CFS group, and we have not found very many people who meet ME/CFS criteria after COVID who also who are free of orthostatic intolerance. So again, it's almost universal in that group. The main thing we look for in the diet is are they getting adequate sodium? Do they have a delayed reaction to milk protein? Are they intolerant of other foods, such as foods that are high in histamine? That can be a problem for those who already have mast cell activation syndrome.
Okay, and then I'm not sure you answered this one. Can you inform us how to make the diagnosis of mast cell activation?
So that's a longer answer, but just be aware that there are two competing diagnostic criteria. One primarily by academic allergy immunology people who insist on an elevation in tryptase at the time of a flare in symptoms. And the other is one that I like better by Larry Afrin, who's a hem-onc specialist who's worked on mast cell activation for decades. And Larry's issue is to find a group of these, or find patients who have a similar range of symptoms that fit. So the rashes, the hives, the itching, and who then respond to something that helps with mast cells like H1 and H2 antihistamines, Singulair, cromolyn. So the improvement in symptoms and function is enough. It's helpful if you check for histamine in the blood. Tryptase is going to be normal in people with mast cell activation most of the time. So it's not helpful like the academic allergy immunology people have proposed. So it's very much an empiric sort of thing. And the nice thing is that the medicines we use to control mast cell activation are really simple, benign things. Cromolyn's another one that's easy to use. Nasal cromolyn is over the counter. And many of the patients just respond to the combination of, say, famotidine and fexofenadine or any of the non-sedating antihistamines.
Okay. And it looks like we have a hand raised here. We got Kelly Wissy. Did you have something?
I do. I just wanted to ask, hypothetically, if you had a patient, say 18 years old, a long distance runner, already on a lot of the things you've talked about, so on birth control pills because of amenorrhea, on some ADHD meds, on some antidepressants already for depression, anxiety, and she goes off to college, has a big change in her diet, gets very fatigued. Yeah, anyway, say she's so her situation has changed, her diet has changed, her sleeping has, everything has changed. And she tells her parents she's very, very tired. She can't run now. Her arms, she's getting aches in her arms. I, of course, she would go to the local healthcare provider, but how would you anticipate changing meds around to accommodate her if she's already on a lot of these things?
Yeah, so I would want to do a standing test on her and see if we can make her more tired just with 10 minutes of standing. The fact that her arms are achy, I'd want to do some testing looking at brachial plexus dysfunction like you'd see with thoracic outlet syndrome, which can affect runners. More often it's overhead athletes, volleyball players, pitchers in baseball, but a physical therapist can help you a lot with that. Then if we've confirmed orthostatic intolerance, you can try medicines from those different categories. So Florinef, pyridostigmine bromide was very helpful for one of the long distance runners we had at Hopkins. We've even had some people get a nice global benefit from naltrexone, like Jessica mentioned, is being studied in the long COVID group. That one needs to be compounded. Or you could try, if she's already on stimulants, you probably don't need to increase the amount of vasoconstriction. You probably want to bring up her blood volume or control the autonomic tone. But it's a bit fiddly, but there's likely something going on. And as you mentioned, you'd want to focus on what changed in her diet. Is she a kid who developed a milk protein intolerance after COVID, which can happen? We often see a pattern where babies are very spitty and colicky as infants, then improve when they're switched off milk protein to soy. They become tolerant of milk protein for many years. Then, after an infectious insult in adolescence, their immune system reverts back to what it was like as an infant. But because it's happening at the same time as the entire illness, they don't focus on milk. So I would want to just look at whether she's eating yogurt more, for example, to try and be healthier.
Interesting. Thank you.
Sure.
All right. And we have one more question that says, what is the magnesium level in these patients?
We don't check that all that often. We often use magnesium as a way of helping prevent migraines or magnesium malate to help them get to sleep if they have insomnia. But I don't know of any studies that have looked at a large group of these patients and checked the magnesium levels.
Okay.
Dr. Rowe, do you mind
sorry.
if I ask one more question?
Yeah, go for it.
Dr. Rowe, how much gastroparesis are you seeing amongst these patients or in the long COVID patients?
So we see a fair bit of GI motility disturbances. I think that's in part because many of them already have joint hypermobility. And if you look at neurogastroenterology clinics where they look at gut motility, the hypermobile kids often have much worse motility than people who are not hypermobile. So they can get gastroparesis. Constipation is a big problem. And so, treating those as well as you can be quite a challenge.
It looks like that's all of the questions we have in the chat. We're coming up on 5 o'clock, which is the time we had slotted for it. I just want to thank everybody for joining today. Thank you, Dr. Kasut and Dr. Rowe, for presenting.